We are live, huh?
Good evening and welcome everyone to the DOS Postgraduate Education Program. As you all know, we are currently in the third module and we have already discussed a lot of topics in strabismus and neuro-ophthalmology. And today we are touching upon a new subject, that is the pupillary pathway. We have an eminent speaker with us today, that is Dr. Anupam Sahu, who's going to take us through this class on pupillary pathway. And we are today in the 25th lecture of neuro-ophthalmology. Dr. Gunjan Saluja, who's been there with us throughout the module, will be moderating this session. She's done her post-graduation and senior residency from the prestigious RP Center, AIMS, New Delhi, and has over 50 publications in various national and international peer-reviewed journals. She's the assistant editor in IGO for the specialty of squint and neuro-ophthalmology. Dr. Anupam Sahu is a consultant ophthalmologist at MGMI Institute at Raipur. He has his specialties in the field of pediatric ophthalmology, strabismus, and neuro-ophthalmology. He has various research papers to his credit, which has over 120 citations with an H index of 5. He has various national and international presentations and has also been awarded fellowship from the Arvind Eye Hospital. He's done his DNB, MS, and MBBS, and has also received various awards, especially the Professor Kamlesh Award for his best free paper presentation, and the AIOS IGO Best Publication Appreciation Award, and Dr. A.D. Patwardhan Gold Medal for his MS in ophthalmology. So with that, sir, we welcome you to the DOS-PEP platform for your talk on pupillary pathway, and we'll be happy to hear from you on this topic.
Thank you, Dr. Pranita, and thank you, Dr. Gunjan, for inviting me for this DOS platform. And I think it's a very good platform that you are having out here. So I think without much delay, I'll start with the presentation. So is my presentation visible?
Yes, sir.
Yeah. Okay, so good evening, everybody. I'll be talking about pupillary pathways. So I do not know what all has been spoken till now, but then pupillary pathways is an important part of neuro-ophthalmology and eye as such, because it tells us a lot about what is going inside the eye. And basically these pathways are pathways that leads to certain reflexes that help us in identifying things that are going on with the optic nerve, retina, and the visual pathway up to a certain limit. So what is a reflex? A reflex is basically an involuntary response that is usually associated with protective or neuroregulatory or regulatory functions. They require a receptor, an efferent neuron, efferent neuron, and effector to achieve a desired effect. So in the eye, what is the purpose of a reflex? So basically a reflex is needed in the eye to control the amount of light that is coming into our eyes. For example, we are all seeing screens and all. So the more amount of light that comes into an eye, it will lead to more of the photoreceptor bleaching, and that will lead to further damage to the photoreceptor. So to control that, we need these reflexes. So in the eye, what is the receptor? It is basically the photoreceptors, and more importantly, the retinal ganglion cells, or there are the intrinsically photosensitive retinal ganglion cells, which are supposed to play a major role in our pupillary reflex. Okay, so we need to know which is the afferent pathway, the efferent pathway, and the effector, which is going to lead to the effect of the pathway. So in our case, as I said, it controls the pupillary size and involves two main systems, the parasympathetic pathway and the sympathetic pathway. These pathways, they ensure a proper light entry for vision, and the parasympathetic system, it leads to miosis, and the sympathetic system leads to a mydriasis. So this is how we manage the amount of light that is coming into our eye. And how do these two pathways act on our eye? Basically, they act on two things: the sphincter pupillae, which leads to a constriction of the pupil, and the parasympathetic pathway acts through the sphincter pupillae, whereas the dilator pupillae, it is the sympathetic pathway, and that constricts the dilator muscles, and that leads to a dilatation of our pupil, leading to more light into the eye, whereas parasympathetic system reduces the amount of light that is coming into our eye. And both of these are present in the iris that we have in our eye. Now we know the receptor and the effector. Now coming to our pathway. So this is the pupillary light reflex pathway, and as you can see that it is a complex pathway. Unlike other reflexes that are present in our body, most of the pathways are unilateral. Okay, the deep tendon reflex on the right side is present, on the left side is absent, so that will tell us something about the brain. But then with the pupil, the effect is much more complicated in the sense that there are double decussation, and those double decussation lead to bilateral response to the light reflex that we are going to use. So let us go through the pathways one by one. So the afferent pathway, as I said, that the retinal ganglion cells are the most important part that leads, that are the receptors that goes through the optic nerve to bilateral tract. Okay, let me just see if we can do it from this photo. Okay, so there is a light to the left eye, and the afferent pathway is going through the optic nerve to the optic chiasma, where it decussates at both to both sides, and from near the lateral geniculate body it goes to the pretectal nucleus, where again there is double innervation to the Edinger-Westphal nucleus on both sides, and that then goes to the uh, third nerve, third cranial nerve to the eye. So let us see. The retinal ganglion cells goes to the optic nerve to bilateral tract. That is the first decussation, then goes to through the brachium of superior colliculus to the pretectal area of midbrain. And from there, the internuntial fibers. So this is the afferent pathway. And then the internuntial fibers are basically relay fibers that go up to both the afferent, the Edinger-Westphal nucleus, which is the parasympathetic nucleus of the third nerve. And the efferent pathway is the oculomotor nerve. The preganglionic fiber goes up to the ciliary ganglion, and then the short ciliary nerves carry the postganglionic fibers to the M3 muscarinic receptors, and that then help in contracting the iris sphincter or the smooth muscle. Now, we all know about the pupillary light reflex. That is what we see most commonly. But then the pupillary light, the dark pathway is as important as the light reflex pathway, because in the dark, this is the pathway that is stimulated, and it's a play between both of these that helps us in identifying what could be the pathology in the eye. So coming to the dark pathway, you can see that it goes through the through the sympathetic plexus, and basically this stimulates the hypothalamus, from where it goes to the sympathetic plexus near the T1 to T3 segments, and from there it goes into the superior cervical ganglion, that is the preganglionic sympathetic fiber, and from there it goes through the postganglionic fibers via the carotid plexus through long ciliary nerves up to the dilator pupillae. So that is the pupillary dark reflex pathway. So let us recheck that once more. It goes from the retina to the optic tract, from there to the hypothalamus, from where it goes to the spinal cord T1 to T3 level, where you have the ciliospinal center of Budge. And from there, it goes through the, it gives off the sympathetic preganglionic fibers, which then go up to the superior cervical ganglion. And from there, they go to the postganglionic fibers, which go through the long ciliary nerves and supply the dilator muscle of the iris. So what is the clinical importance that we need to give to this pupillary pathways? The most important clinical consideration that we need to think of is relative afferent pupillary defect. Okay, so that provides us a lot of details about how the eye is how the eye's optic nerve pathway and the retina is present without even seeing the fundus. So relative afferent pupillary defect basically means the same thing, relative afferent. So afferent means the afferent pathway is involved, and it's a relative defect. So in cases, for example, where there is a total optic atrophy in both eyes, no PL in both eyes, what is the response that we see? We do not see any response in both the pupil. Both the pupil are mid-dilated. They do not react to light. So that is a total afferent pupillary defect. Whereas relative afferent pupillary defect is something that we use more frequently in our clinical practice, because this asymmetric afferent output provides us a lot of clinical findings. So in this case, the lesion has to be present along the afferent pathway that we have just seen. Okay. So when light is shined on the affected eye, there will be dilatation of both pupil due to the abnormal afferent arm. So this will happen when there is a abnormal afferent arm. The pupil will not constrict on the same eye, and the other eye also the pupil will not constrict because the consensual reflex will not be present. So we'll come to that in the video later on. Coming to the detection of RAPD, it requires both eyes. Okay, but can we see it with only one functioning pupil? Yes, you can see that provided the other eye pathways are normal. So if the second pupil is unable to constrict, say there is a third nerve palsy in one of the eyes, and you also see that the pupil is dilated. How do you know whether it is because of the efferent pathway or because of the afferent pathway? Then we do the reverse RAPD test, and this is done in the normal eye. So you see both the direct and consensual response in the normal eye, and that is how you then evaluate whether the third nerve palsy is also associated with a optic nerve pathology or just a efferent pathway defect. So what we will see if there is a no RAPD in the left eye. In the right eye, suppose the left eye has a third nerve palsy and the right eye is normal. So in those cases, in the right eye, what we will see is the direct response will be quick and brisk. And when we throw light on the left eye, then again the reaction would be equally brisk in the right eye. And that will tell us that both the direct and consensual responses are present in the right eye. Whereas when we throw light on the right eye, you will not see a response in the left eye. With both the direct and consensual will be absent in the left eye. We'll come to that once more. So now coming to this video. So this is a very important part of the evaluation. How do we actually check for the pupillary reflexes and how do we identify where the pupillary pathway is affected? So you have a almost dark room with a light that is falling on both the eyes. You can use the overhead lamp and it should be such that both the pupils should be visible as in this case. And then you show a bright pointed focused light beam on each eye. So in this case, you can see that if you are throwing light, so there's a swinging flashlight test, but even in that, you can see that when you are throwing light in the right eye, the pupil is not dilating as well. And in the left eye, it is constricting very well. The response is brisk. Okay, so this is a swinging flashlight test. What is it done for? It's done for RAPD or a relative afferent pupillary defect. It will not work with a total afferent pupillary defect. And in normal cases, you will see equal response in both eyes. How do we see? We see the eye on which we are throwing that light. Okay, so you see the right eye, then you see the left eye. And you can see that there is constriction in the left eye, but as soon as you throw it in the right eye, it constricts a bit and then it dilates much more than it was previously. In this video, you can also see that both the direct and consensual can also be appreciated. So let us look at the right eye first. You can see that the direct response is sluggish constriction of the pupil, which then redilates pretty much as soon as it constricts. Whereas in the left eye, you can see that the direct reflex is brisk. Okay. Now coming to the consensual reflex. When you throw light on the right eye, when it is thrown on the right eye, you will see that the left eye is not constricting very well. Whereas when you throw light on the left eye, you will see that the right eye is constricting much more than it was constricting with the direct reflex. And that suggests that the right eye pupillary response, the afferent pathway is affected. Okay. So there is a bit of a confusion. Whenever students see this for too much time, there is a lot of confusion that is it an efferent pathway or an afferent pathway. So let us come to both separately. I hope this part is clear enough to everybody. So coming to an afferent pupillary defect. So what happens with an afferent pupillary defect is that we know that the lesion is in the retina or in the optic nerve on the same side. Okay. So when you throw light on the affected eye, there is no direct response and no consensual response, or there's a not a very brisk direct and consensual response. Whereas light in the normal eye, both pupils constrict. That is, the pupil in the left eye and the right eye, both will constrict normally because the efferent pathway is normal. Okay. Whereas, why does this happen? Because the afferent pathway is going to affect both eyes, whereas efferent pathway will affect only one eye. So, if neither eye constricts when eye is shown in one eye, think of cranial nerve of the optic nerve. Whereas, think of the cranial nerve 3 when you throw light in either eye and the normal eye constricts and the affected eye does not constrict whatever you do with it. That is the efferent pathway defect, and that affects only one of the eyes. And the motor efferent pathway to the sphincter pupillae is damaged, so that eye which is not reacting to either direct or consensual is having the efferent pathway defect. I hope that much this difference is clear. This is very important difference, that we need to identify whether the afferent pathway is involved or the efferent pathway is involved. Once we identify that, we are already able to remove certain things from our diagnosis. And there will be associated signs, of course, we'll come to that later. So it can have, say, third nerve palsy with slight, even early onset of third nerve palsy might have some amount of ptosis or down and eye out position. So that will confirm your diagnosis of an efferent pathway defect. Coming to the next important part, that is anisocoria. Okay, so when we see both pupil, one of the things that patients can come with an asymmetric pupil, and that again is many times the effect of a pupillary pathway defect. And how does that affect us? Because that again leads to multiple diagnosis and it becomes very, so whenever you hear about anisocoria and questions about anisocoria, this table comes to your mind. But before this table comes to your mind, ask one question. Whenever such a patient comes to you, is the anisocoria worse in light or dark? So the first step that you do with these kind of patients is check for the anisocoria in both lighted condition and in a dark room condition. So when the room is fully lit, at that time when you see, just evaluate the amount of difference between both eyes, and then totally dim the lights and then put the overhead lamp and then once again check. So if the situation is worse in lighted condition, now we have already seen which pathway, which of the reflexes is important for protecting our eye from light, and that is the parasympathetic pathway, which helps in constricting the pupil and prevents light from coming into the eye. So if the situation is worse in light, it means that the parasympathetic system is not able to protect the abnormal eye from light, and that's why more dilated. Whereas if the situation is worse in dark, it means that the dilator system is not working well and there is a sympathetic pathway problem, and which could be, so basically if we are looking at pathway problems, it can be either a cranial nerve 3 problem or a Horner syndrome based on the anisocoria. Okay. So now coming to this table that we see. So you have already identified, okay, your case has, let's come to the right side of the table first. Your patient has worse anisocoria in a lighted room. So as we have seen, which one would be the pathologic eye? The one which is not constricting, that is the pupil that is abnormally large. So if the pupil is large, what could be the factors? You'll of course ask for an history of trauma and other things, because that can also lead to traumatic mydriasis and all. But if there is no history of trauma or other findings, or if there is no history of, another thing that you would need to rule out is any drops that have been put into that patient's eye. If these two things are not there, then you look for ocular motility and ptosis. If they are also not there, okay, so if they are present, then you consider a third nerve palsy kind of picture, and you advise neuroimaging and other conditions and other examination investigations for these kind of conditions. Whereas if the ocular motility and ptosis is not there, then you start suspecting AD's tonic pupil. In today's this thing, we talk about the tonic pupil. So what is the AD's tonic pupil? It is a hypersensitive kind of pupil. In these cases, if you have pilocarpine 0.125 available, then if you put it, these kind of pupil constrict. Well, we'll come to that again later on when we talk about the edystonic pupil. But then if the pupil is dilated, then these are 3 or 4 differentials that you have. Trauma, mydriatic drops being placed, being put into that eye. It could be an internal ophthalmoplegia also if there is no other oculomotility defect, or an external ophthalmoplegia due to third nerve palsy, and or a edystonic pupil. Okay, so these are 4 differentials that you should keep in mind. Now coming to conditions that are worse in dark. Now worse in dark, one of the conditions that can be present is physiological. However, that is something that we put as a diagnosis of exclusion. So we'll first need to rule out certain other things. So how is which one would be the abnormal eye in this case? If it's worse in darkness, that means the pupil is not able to dilate. The abnormal pupil is not able to dilate that well. And that would indicate that the smaller pupil is the abnormal one, because the normal pupil has dilated good enough because the sympathetic pathway is working well for that eye. So the smaller pupil is abnormal. In that eye, then you again check for, one is mild amount of ptosis, you check for anhidrosis on that side, and you also check for uh, the other findings that can be present with a Horner syndrome. If they are present, then you suspect Horner syndrome. In these cases, it's usually better to get a MRI or MRA done to rule out any pathology that is present along the sympathetic pathway, especially the cervical and thoracic area. Okay. But if none of that is present, then you can consider it as a physiological anisocoria. So anisocoria is another important part that we need to understand with a pupillary pathway defect. So coming to Horner syndrome, what is that? We know that it's basically, I'll not go into the details of the Horner syndrome, but then it's basically something that affects the superior cervical ganglion area. And once the superior cervical ganglion is involved, it also innervates the facial vasculature, sweat and lacrimal glands, and the eyelid tarsal muscles. And that's why you get the mild amount of ptosis because of in Horner syndrome cases. So when these are damaged, it's known as Horner syndrome, which is characterized by meiosis, anhidrosis, pseudotosis, and inophthalmos. So these are the 4 classical features that you get. You may not get them, and always in cases with acute presentations like this, where the pupil is smaller in in a dark room, always get a MRI done to rule out a Horner syndrome, because that can be associated with Pancoast tumors and other cervical or thoracic area abnormalities. In this case, remember that the light reflex is normal. When you evaluate the pupillary response in lighted conditions, you will find that everything appears to be normal. So you do not miss out on the anisocoria in these cases. Okay. So now let us come to another scenario. Okay, a patient complains of pain in her left eye. Left eye appears to be, pupil appears to be dilated and is not reactive to light directed at either the left or right eye. Okay, so the left pupil is not reacting to light. We have already seen the condition that can be present. Okay, the right pupil appears normal in size and reacts to light when it is directed to the right or left. So the right pupil appears to be normal with both the direct and consensual in the right eye appear to be normal. Eyelid movements are normal, the ocular motilities are normal, and touch, vibration, position, and pain sensations are normal over the entire body and face. And there are no other motor symptoms that are seen in this patient. Okay, so this is the kind of scenario. How do we move forward whenever we see these kind of anisocoria or pupillary conditions? So you look at the direct response and the consensual response and make a note of it. So in this case, you note that the left pupil is not reacting to light directly or consensually, and the right pupil is reacting to light directly and consensually, and they are normal eye movements. So we remember that table, right? And so what does that mean? That one eye is not responding to either direct and consensual. So that makes it a efferent or a motor dysfunction. And it affects the pupillary light reflex pathway because it's responding more in the light. Okay, so the effect is more gross in the lighted environment. So in this case, as you can see, that the pupillary light reflex loss, it involves only one eye. It is involving only the motor function and does not involve eyelid or ocular motility, and is limited to pupillary constriction in the left eye. So this tells us that it could be a affection. So where can be the effect in these kind of cases? So you say that AD stonic pupil is there, but then where exactly is the effect in those cases? It's usually at the level of the ciliary ganglion or the short ciliary nerve, because that then excludes the motor part of the third nerve. The motor part is working well, but the ciliary ganglion or the short ciliary nerves are getting affected, which is leading to the AD stonic pupil. So when a patient is affected with AD stonic pupil, when the patient comes acutely to you, at that time you will see that there is a dilated pupil. But over a period of time, you will see in these cases that the pupils start constricting slowly. The constriction is again slower than the other eye, but the amount of constriction is many a times much more than you see, and the amount of time that it stays constricted is much more, and that is because of a denervation supersensitivity that occurs in the postsynaptic receptor. So the ciliary ganglion is damaged, maybe the short ciliary nerves are also damaged. But then the receptors start getting a denervation supersensitivity, and even small amounts of acetylcholine lead to increased constriction of the sphincter pupillae, and that leads to the tonic pupil that we see in these patients later on in their life. Okay, and that also happens because of the aberrant re-innervation that happens, and this re-innervation mostly goes to the pupillary area. We still do not know a lot about how these things actually work, but then this is the kind of function that it usually leads to. And so that also leads to a light near dissociation many a times in these kind of patients, where for near, that is the convergence reflex is working, but the light reflex is not working very well. So that is the light near dissociation that can affect these kind of patients because of aberrant regeneration to the pupillary muscles rather than to the other parts of the eye. And the tonic reaction is the result of iris sphincter supersensitivity. We have already talked about that. Now coming to the near reflex, which again is an important part of our pupillary reflex. Why? Because the pupil needs to be adjusted whenever the eyes are looking from distance to near. So the near reflex basically has three parts, we know: accommodation, convergence, and the pupillary constriction. So these basically are acted upon by two pathways, that is the convergence reflex pathway and the accommodation reflex pathway. So both these pathways have different stimulus, that is the receptor method is different. So for accommodation and convergence, there is retinal blur. So retinal blur is one part. So as soon as you bring something near, there is a retinal blur, which stimulates the accommodation and convergence. And as soon as something is brought near, the proximal convergence is also stimulated, and which leads to an image disparity, which again leads to pupillary constriction, because less amount of light needs to be brought into the eye, and a depth of focus needs to be increased. So the pupillary constriction also happens. So these are the actions that lead to these findings. That is, we have a clear focus, the depth of focus is increased, and we are able to focus as a single image for near. So what are the efferent limb for these? Now, for the accommodation reflex, the pathway is considered to be much more complex than for the near reflex. In fact, this pathway goes from the retina to optic nerve to optic tract, to the lateral geniculate body, and from there it goes to the striate cortex, and from there to the parastriate cortex, from where through the occipito-mesencephalic tract it goes to the pontine center, and from there the signals go to the Edinger-Westphal nucleus and medial rectus subnucleus. So it goes to these different areas, from where the Edinger-Westphal is the parasympathetic pathway, which will again go and stimulate the accommodation, and the MR subnucleus will lead to the convergence effect. So that is the pathway that is as of now considered to be working for accommodation reflex. Whereas for the convergence reflex, what happens is, as soon as you start, there is a proximal convergence, stimulation goes from medial rectus to the mesencephalic nucleus of the fifth nerve. That is, these are sensory motor pathways, and that then goes to the pretectal convergence center, and from there the internuntial fibers go to the Edinger-Westphal nucleus, which then constricts the pupil via the pupillary light reflex that we have seen, but without the light stimulation that is noted in those cases. So that's the efferent limb. The efferent limb is the motor output pathway, which goes to the cranial nerve fibers to the medial rectus and ciliary ganglion. So the pathway is almost same for all of these, the output pathway. So the postganglionic fibers, that is the short ciliary nerves, then innervate the ciliary muscle, which contracts, relaxing zonules, making the lens more spherical, which is the accommodation that we are attempting when we are looking at near. And sphincter pupillae contracts, which leads to a meiosis. And this meiosis helps us in providing a depth of focus for near. And medial rectus muscles, also it goes from the medial rectus subnucleus, which then contracts for the convergence which is needed. Otherwise, we'll have always diplopia for near. Okay, so the result is a single clear vision of the near object with a good depth of focus. So accommodation, convergence, and meiosis, all three lead to a near reflex. So these are the major reflexes that are affected by the pupillary pathways. I hope I have not missed on too many of these pathways, but then this is the near reflex pathway. On the left side, you can see that is the convergence pathway, which starts from the medial rectus and goes via the pontine center to the constriction of pupil, whereas the accommodation pathway, it goes via the retinal, the optic nerve, LGB to the striate cortex and the parastriate cortex. And from there, it gives multiple outputs to Edinger-Westphal nucleus and the MR subnucleus, which then lead to the convergence and accommodation in the eye. So this is the near reflex pathway. So these are, I guess, the major pupillary pathways that we need to know of and the major clinical repercussions of these pathways. Um, Another interesting part is the ciliospinal reflex. So this reflex is basically a pupillary dilation. So my first reflex pathway, if you would have noticed, was the response to a pain reflex. Okay, so along with that pain reflex, there comes the ciliospinal reflex, which occurs in such conditions where our sympathetic stimulus is involved, which goes into the fight or flight reflex that we know of. So that leads to dilatation of the pupil. Why does dilatation happen with all these sympathetic pathway reflexes? Because we need to have more light. The eyes, the body needs more light to focus on things, and that leads to the fight or flight reflex. Uh, if things are getting too complicated, maybe we can then avoid this part. So that is all about the pupillary pathways. I've tried to keep it simple, and I hope those who have been watching have been able to get the point of the pupillary pathway. So the trigeminal nerve or the cervical. So this is the ciliospinal reflex pathway. If people are interested, the trigeminal nerve or cervical pain fibers, they lead to the efferent sympathetic neurons, which then exit the cervicothoracic cord, again from the C8 to T2 area. And from there, the third order neurons go from the superior cervical ganglion up to the internal and external carotid arteries, and pupil receives the sympathetic innervation and dilates. So that is all about the pupillary pathways. So I'd like to thank DOS once again, and Dr. Gunjan, Dr. Pratima, everybody for their for inviting me for this presentation. I hope it had been a clear pupillary pathway, because that's a very difficult thing to explain. So Dr. Pratima, Pranita, sorry, anything else you would like to add to this?
Yes, sir. Thank you, sir, so much for that wonderful presentation. I think we have Gunjan here. And Gunjan, are you there? I think it is a really important topic because our next discussion is going to be on the pupillary disorders related to the pupil, wherein we'll be discussing various clinical aspects. So it is very important that we discuss all the basics that you have discussed here today. And I'm sure Gunjan has a lot of questions to ask you. She'll be joining here just in a minute.
Yeah.
Good evening, sir. Thank you for that wonderful lecture on pupillary pathways and their abnormalities. We have almost covered everything and all the abnormalities which we see usually in our day-to-day clinics. I have one question, sir, regarding AD stonic pupil. So, for the postgraduates, usually, as you rightly mentioned, that there are questions which are asked in the ICO examinations also, and even in the FRCS examinations if they are appearing for about the pupillary examination. So, for the AD stonic pupil, do they require to do MRI for each of the case of AD's pupil? And usually, the concentration of pilocarpine that is available is 2%. Rarely we get 1.25%, and then how to dilute it, if you can throw some light on that.
Okay, so we have actually stopped doing that. Earlier, I used to do that. So even that 0.1%, nowadays we have that new drop, right? That is, I think, some 0.1%. So that is one thing you can try. But even otherwise, you can actually dilate it with lubricant eye drops. The amount I'll need to calculate because I have stopped doing it right now. Anyways, all these patients, you need to get an MRI done initially just to rule out any other condition. Earlier, this was associated with syphilis and other, the Argyll-Robertson pupil and all, but nowadays it's not a very common finding. It depends on the time that the patient has presented to us. So I usually get a MRI or at least a CT scan done with the orbit to rule out any mass that is present in the orbital area, especially around the ciliary ganglion area, or even sometimes these patients may have other infective disorders. So it's better to get one done if the patient is presenting to us acutely. I think that,
Yes.
yeah. And about the
Yes.
pilocarpine, you'll need to read about that part, or maybe you can tell about that if you are doing that, because I'm not doing it right now.
No, we do not do, but what is written in the textbook is like the pilocarpine test, like 0.125% pilocarpine that has to be instilled, and there is parasympathetic hypersensitivity that is seen, that you had rightly covered it. Second thing, so someone is asking about Parinaud syndrome.
Okay, so paranoid syndrome, it usually, I've excluded all that because that is a bit more complicated. But then, yes, paranoid syndrome and all, if you have getting, so these patients usually have multiple conditions. They have convergence retraction, they will have nystagmus, they won't have, your elevation will be defective. So it affects the pretectal area and the tectal nucleus basically, along with the other pathways, medial longitudinal fasciculus and these kind of which affect our gaze. So in those cases, what will happen is because your tectal nucleus is affected, your the internuncial fibers that are coming from the tectal nucleus to your Edinger-Westphal nucleus, they will be affected. So your response in both eyes should be affected in these cases if it is affecting the tectal nucleus area. So it is more complex. It has multiple paths to it. So, but yeah, it will, in this pathway, paranoid will affect the tectal nucleus area, the pretectal
Yes.
and tectal area.
Yes. Okay. So thank you, sir, for the wonderful lecture again.
Yeah.
Pranita ma'am, are you there? We can present the certificate to sir.
Should I stop sharing this? So there's a good initiative by you people. So
Thank you so much, sir, for that. You have some more questions, Gunjan?
I think that was enough. These were the questions which were there. We have discussed with sir. Two, three questions were only there. Sir has already covered a lot in his lecture.
Yes.
I
Thank
hope
you
it
so.
was because pupillary pathways after some time it becomes confusing for children. So I tried to keep it short.
Yes, sir. And I think a lot of key points that you were highlighting of anisocoria and light and dark, all of these are often asked in MCQ question, even in the SR entrance and a lot of other places. So I think that was really helpful to bring those key points in. And we are really thankful to you, sir, for joining us this program of Delhi Ophthalmological Society, and Dr. Praful and Dr. Rajesh Sinha, who mainly thought about this program for the postgraduate students, and rightly highlighting all the vital points for the postgraduate students. This is an appreciation certificate from DOS, and surely please do join us for the annual conference of DOS next year in April. And we'll be, if possible, if you do join us, we'll give you a frame certificate for the same as well.
Sure.
Thank you
We'll
so
try
much, sir.
that. Thank
Yeah. And also, if you could share a PDF of your PPT, we're planning to share the entire module of the strabismus and neuro-ophthalmology with the students. If you could share a PDF of your presentation, we would be sharing that with the students who are associated with in this PEP module.
Okay, sure. I'll do that with Dr. Gunjan then.
Yeah.
Yeah.
Thank you.
Okay.
Thank you so much, sir.
Thank you. Thank
Sure,
you,
sir,
Dr.
sure.
Sunita.
Thank you. Thank you.
Thank you.
Thank you. So with that, we come to an end of this session. Thank you and good night, everyone.
Thank you.